Hello, let's talk about this SDL titled Malt, Lymphomas, and Gastrointestinal Stromal Tumors. We will also discuss carcinoid tumors of the GI tract. So the text begins with a discussion on mucosa-associated lymphoid tissue. I trust you know what that is already. It's essentially the interface between your body and the outside world, and it has an immunological function. Lymphomas, that's a type of neoplasm that I do not believe we've encountered before in our curriculum too heavily. A lymphoma is a neoplasm of lymphocyte origin, and a lymphocyte is a specific type of white blood cell from the lymphoid lineage. Remember that they derive from hematopoietic stem cells, and then they differentiate into T cells and B cells. Those are your lymphoid cells, as well as natural killer cells, but we're not talking about those right now. And then that's in opposition to your myeloid lineage, which contains things like macrophages and granulocytes. So a lymphoma is an immune cell cancer. And it's malignant, meaning it can spread. It's invasive. And that makes a lot of sense because the individual lymphocyte is not beholden to any particular tissue. There's nothing that says, oh, hey, you have to stay in place here, as opposed to, say, the brain. A neuron's not going anywhere, is it? A neuron is not going to migrate anywhere. But a white blood cell, well, that's the role of a white blood cell, is to be mobile and to be able to creep into any injured tissue and respond to chemokines. So because of these inherent features, well, whenever you develop a cancer within a lymphocyte, it's automatically got this access to the bloodstream that other cancers don't really have. So unless it arises within a patch of malt, it's not really going to be anchored too heavily to anything. And lymphomas do often present as metastases of a primary lymphoma. And so the clinical presentation of that, the symptom that you see is lymphadenopathy. And the lymphadenopathy is a very common question lead in on exams, and it's a good differential to be able to pull out of your pocket in real life too when a patient comes in with a lymphadenopathy. There are multitudinous infectious causes, as you can imagine. There are also autoimmune causes of lymphadenopathy. Any immediate proliferation of B cells or T cells, especially those reactive proliferations of B cells, whenever you go ding, 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 we found the right antigen, and you start making antibodies against it, well, then that B cell goes through clonal proliferation, doesn't it? So that might be the reason why you've got a lymphadenopathy. And a good example of that we have discussed very recently is Sjogren's syndrome. And then you can get a lymphadenopathy from some different drugs. And then, of course, there's different malignancies that could congregate metastatically within a lymph node, and you ought to keep that on your differential, and it ought to be towards the top, especially if it's a firm, non-tender, non-painful lymphadenopathy. So that's usually how it looks like in a question if you've got to make the diagnosis. But there's a lot to test about with lymphomas. Definitely on the genetic side of things. And so oftentimes they might just give you that, hey, this is a lymphoma, like very obviously, and then ask you about some arcane detail, and that's just the way she goes. So we classify lymphomas as Hodgkin or non-Hodgkin. And we don't know nothing about Hodgkin yet. Us unlearned medical students who have not encountered it in our curriculum. But Hodgkin lymphoma is essentially any lymphoma that exhibits Reed-Sternberg cells on histology. And that's a discussion for another time and place. Non-Hodgkin lymphomas are the majority of lymphomas. And they do not present with Reed-Sternberg cells, as you can imagine. At least 1/4 of non-Hodgkin lymphomas are extranodal, meaning that they arise from tissue other than lymph nodes. So when a patient does present with lymphadenopathy and it is malignant, well, that could be your primary cancer, true, or it could be a metastatic cancer from a different primary origin. Now we finally get to the definition of a MALToma. MALTomas are marginal zone lymphomas, which means they have a B cell origin, specifically a memory B cell origin. And your memory B cells are the ones that hold on to specific antibodies for a very long time, just in case you encounter that one pathogen or antigen ever again. You can pull out that antibody and mount an immune response. And they stay in the marginal zone of lymphoid follicles. Remember that within Malt, you've basically got patches of B cells surrounded by T cells, islands of B cells surrounded by an ocean of T cells. That's the architecture of your Malt. And so the marginal zone of a follicle of an island of B cells is exactly what it sounds like. It's right around the rim. It's right around the margin of an island of B cells. So marginal zone lymphomas most often develop as extranodal lymphomas, meaning that, yeah, you find marginal zones in your lymph nodes because you have follicles of B cells in your lymph nodes, but you also have follicles of B cells in your mucosa-associated lymphoid tissue. So when you get a cancer in a B cell follicle around the periphery of the follicle, in a patch of mucosa-associated lymphoid tissue, be it in the small intestine or the tonsils or wherever, that's called a MALToma. It's an extranodal marginal zone B cell lymphoma. It's a clonal neoplasm, and that'll come up again when we talk about how we diagnose it. Finally, MALTomas frequently recur locally and do have potential for transformation to a high-grade B cell lymphoma. Recall grading versus staging. Staging, we're thinking S for spread. How far, in what direction has a neoplasm, has a cancer spread? And for grading, we're thinking about the growth of the cancer, and we're trying to qualify that at the microscopic level. And we kind of have tiers of grading based on how dedifferentiated a cancer is, meaning, well, if a cancer is well differentiated, it looks just like its neighbors. It looks like the tissue around it. It looks like what it's supposed to look like. But if it's dedifferentiated, it's all anaplastic with nuclear atypia, and it might have a high degree of mitosis. And so those things are associated with dedifferentiation, which is built into the definition of a high-grade cancer. Where do we find MALTomas? Well, mostly the GI tract. Again, you find Malt wherever your body is interfacing with the outside world and your gut has a lot of surface area. So this makes sense. The stomach is the organ affected in the majority of cases, followed by the small bowel. You don't tend to see colorectal lymphomas. If you do see cancers down there, then they tend to be related to polyps, precursor lesions. At the bottom of page 3 is an important section. And I believe that this is where an exam question will come from, because we rarely get asked, oh, what's the diagnosis, you know? They got to ask us a second or a third order question, something other than just what is this? And so a good thing to ask us would be, well, what predisposing factor did this patient most likely have? And if we look at this list of predisposing conditions, we see that there are some different risk factors associated with some different types of cancer. So we're basically just playing the match game here with this part of the SDL, and you don't have to be an expert on immunoproliferative small intestine disease, for example, to understand that Campylobacter jejuni infection might predispose one for IPSID, which is also known as alpha chain disease. So be able to recognize all these synonyms for different diseases because they could get thrown at you anyway in a question stem or in an answer choice. Now, Helicobacter infection is highly associated with the development of Malt lymphoma of the stomach and to a lesser degree, other sites in the GI tract. Most patients with Malt lymphoma are H. pylori positive. And what's really interesting is that for many lymphomas directly attributable to Helicobacter, the cancers will just go away if you get rid of the Helicobacter. So with triple therapy or quadruple therapy, get the right drugs in there and the cancer will shrink. There's one type of MALToma that won't because it's not very related to Helicobacter, but that's the exception and we'll cover that. So please understand that antibiotics targeting Helicobacter ought to be at the top of your therapy goals. The development of Malt lymphomas is due to the clonal expansion of B cells that accompanies chronic gastritis in the presence of H. pylori. This should make a lot of sense to you. Helicobacter presents antigens and B cells kind of play the match game and they say, oh, hey, do you got the right antibody? Do you have the right antibody? Do you have the right antibody? Like, I don't have the right antibody, you know? And so they kind of fumble around haphazardly like toddlers. And it might be for a good long time because it's all random. It's completely random, the recombination of your immunoglobulin molecule, you know, especially that active site to try to make a shape that will randomly fit this antibody generator being presented to it. But when it does, when a B cell finds the correct shape that matches the antibody presented or the antigen presented to it, it blows up and it makes 1,000 of itself. Why? Because it's found the it's solved the equation, right? So any setting in which cells are just proliferating like there's no tomorrow, you should understand how cancer can just spring out of that. And once more, the monoclonality of this response, if sustained, is what helps you diagnose a cancer. Because if it's an infection, you know, like the monoclonality should just go away when the infection's gone, right? But then if you get rid of the infection and they've still got monoclonal B cells, then you're thinking, oh man, like there's a cancer in there somewhere. And every single monoclonal B cell is an exact copy of the origin cancerous cell, maybe with some very minor mutations that it's picked up along the way, but that's the thinking. So Helicobacter is associated with Malt lymphoma, Campylobacter with IPSID, which is a type of Malt lymphoma, a variant or subset of Malt lymphoma. And then celiac disease finally is associated with enteropathy-associated T cell here, lymphoma. And those are 3 predisposing factors for 3 subtypes of lymphoma. And so that's as close to an obvious question as I've been able to find in this SDL besides the genetic stuff. So let's talk about gastric lymphomas, lymphomas of the stomach. These things are CD20 positive, and they've got 3 genetic associations you need to know. The stomach is the most common extranodal site of lymphoma. So again, it's a MALToma, not a nodal lymphoma. And these patients who are affected by a gastric MALToma will have some maybe dyspepsia, epigastric pain, possibly associated peptic ulcer disease, You may even see a lymphoma alongside an adenocarcinoma. So don't, be prepared for anything. Most common presenting symptoms, again, stomach pain and discomfort, anorexia in half of cases. So I imagine that eating would be very troublesome if it hurt that badly to eat whenever you have a sizable lesion in your stomach. Occult GI bleeding, meaning it's occult, meaning melena, meaning dark stool, meaning we're thinking esophagus, stomach, duodenum for localization of that bleed. You might find a palpable mass, but man, you got to be really digging in that stomach unless it's a big MALToma there. And peripheral lymphadenopathy, the disease has metastasized. And if you get a metastasis from the stomach, one of the places it's most likely to go is going to be your left supraclavicular lymph node, which is going to be just outside the lateral margin of your sternocleidomastoid muscle. And this is review for some of you, but remember that's the location at which all of your lymphatics drain back into your bloodstream, correct? And that's the location bilaterally. And the difference bilaterally is that at your right lymphatic duct, when it's pouring back into the bloodstream, it's only draining your right upper quadrant and part of your right lung. And then your left side, that's draining your whole body besides that right shoulder and arm. So many cancers can present with this lymphadenopathy that pops up at the left supraclavicular node. That's what I'm trying to get at. Back to MALTomas. So some of these gastric lymphomas are diffuse large B-cell lymphomas. I don't believe you're going to get asked, hey, is this a Malt lymphoma or a diffuse large B-cell lymphoma? That's just beyond your current talents right now. Histologically, bottom of page 4, Malt lymphoma takes the form of a dense lymphocytic infiltrate in the lamina propria. I'm going to read this whole paragraph. Tumor cells are small to medium-sized with pale cytoplasm. The lymphoma cells infiltrate and destroy adjacent gastric glands to form lymphoepithelial lesions, which are very characteristic for Malt lymphoma and are defined as infiltration of the glandular epithelium by clusters of neoplastic lymphoid cells with associated destruction of gland architecture and eosinophilic degeneration of epithelial cells. So what that's telling you is that the only thing you could possibly mistake this for is a gastritis that's progressed to the atrophic stage, or maybe not a gastropathy. You don't see immune cells in a gastropathy. So that's the only thing you could confuse this histologically with is a gastritis in which the glands just start shrinking and dying. Other than that, I mean, no other cancer that we are going to talk about in this single exam block looks remotely like this. And again, it's in the mucosal layer. Specifically, it's in the lamina propria, which is right deep to the epithelium. And we're referring to the stomach. So you might see that this tumor stains CD20 positive. And that's going to get you thinking Malt lymphoma. And it'll stain negative for 5, 10, and 23. The real big ones to know out of this 6 that are named here, 5, 10, and 20, because that's on our standard panel. According to what I've read, like you ought to be screening for 5, 10, and 20 every single time you see any lymphoma. And 19 and 22, those are just cherries on top if you get given those in an exam question. The tumor cells express IgM, IgG, IgA, and they lack IgD. light chain restriction. The demonstration of light chain restriction is important in the differential of benign lymphoid infiltrates. So what is light chain restriction? Well, remember that B cells make antibodies which have light chains and heavy chains. And the light chains have a type and the heavy chains have a type. And light chain restriction is essentially clonal proliferation is what it indicates, because it says that if you look at all the antibodies produced by a given B cell population, you take a sample, and if they're all making the exact same light chain, then you're like, uh-oh, clonal proliferation going on. So again, if it's not the setting of infection, that's totally abnormal, and you're thinking cancer right there. And normally, when reacting to a presentation of an antigen, B lymphocytic populations produce immunoglobulins containing an almost equal amount of kappa and lambda light chains. So that's what happens when you get an infection, you see an antigen, you start making some kappa, some lambda. But in cancer, it's like all kappa, all lambda. So that's what we're talking about when we say light chain restriction. So that's a very important procedure in the diagnosis of B lymphocyte neoplasms for both lymphomas and leukemias. So I imagine that'll pop up many times more throughout our studies, because we're not done with these white blood cell cancers yet, are we? Here's a photo of an extranodal marginal zone lymphoma revealing strong expression of CD20. I mean, you look at this whole thing and it's nothing but lymphocytes. That's a huge proliferation of lymphocytes. So along with a couple of key symptoms, then you're thinking lymphoma. Let's talk about the genetics. You got to memorize these. I want to say that. And you don't have to know these like the back of your hand. You don't have to be able to teach this to a squirrel, you know, like you just have to literally say, okay, MALToma, 1118 translocation, 1418 translocation, trisomy 3, done. But you ought to understand at least that with the translocations, they do make a fusion protein. And a fusion protein is so cool, yo. Like, that just brings out the nerd in me, yo. Like, how cool does this sound? So you take a gene, right? And you just put it on another chromosome. And you detach it from its promoter, so that whenever this one promoter region on the chromosome that got the translocated gene activates, then you're producing protein number 1 and protein number 2 on the exact same mRNA. And so then when that mRNA goes to get, translated into a protein, you get one protein that's like literally stuck together right there. So you might have like a receptor tyrosine kinase, and then you might have something that like a transcription box homolog, and then they literally come out glued together. That's so cool, yo. And so sometimes these things retain their function, and that's what's so fascinating about them, because it's like you would think that with proteins just being, you know, such an example of like random chance lining up for the good, like how in the world could these two proteins get stuck together and one or even two of them retain their active site activity? I don't know, but it happens. And so sometimes it causes a gain of function, and sometimes it causes a loss of function in these fusion proteins. And depending on whether a given protein involved is an oncogene or a tumor suppressor gene, right? Depending on the proteins involved and depending how much function they gain or lose, man, this could just open the door wide open for cancer. So to sum up fusion proteins, there's no rules of thumb, yo. This is the Wild West scientifically, but sometimes they work. I don't know. Sometimes their active sites retain activity. That's just so crazy to me. So let's talk about translocations more broadly. We can have a balanced translocation and you can have an unbalanced translocation, okay? Now a translocation is swapping genetic material between chromosomes. So translocation is balanced whenever it's even, dead even, all balances, 0. There's no surplus or deficit of net genetic material. Translocations are unbalanced whenever we gain or lose genetic material. So possibly a duplication, right, of a gene, or maybe a deletion of a gene whenever part of chromosome A goes to chromosome B. That's an unbalanced translocation. Translocations are said to be reciprocal whenever two chromosomes trade little strips of, you know, CAGGTA, CAGG, like, and they're Robertsonian when two acrocentric chromosomes interact and one chromosome just takes from the other chromosome and doesn't give anything back. So those are some 4 different types of translocations you might get shown, especially in some of those board review style questions. I can see them loving this topic because it's, I mean, it's really fundamental knowledge, you know, but it's stuff that it's easy to forget after you learn 10 organ systems later. What's a translocation? And some of y'all are sitting there like, So an acrocentric chromosome is one with a short P arm. And a P arm, well, remember, chromosomes have a centromere and they have P arms and Q arms. And so if our centromere, I'm drawing this chromosome on the left, for example, if our centromere is right there in the middle and it's like the center of the cross, so to speak, then your P arm is your short arm and your Q arm is your long arm. And in a Robertsonian translocation, well, a Robertsonian translocation can only occur with these acrocentric chromosomes that have long Q's but short P's. And so some examples of those are 13, 14, and 21 is an acrocentric chromosome. So there's a Robertsonian translocation that can give you Down syndrome. And it's a 14-21 Robertsonian translocation. And in this case, you would see Down syndrome with 46 total chromosomes because of the Robertsonian translocation. And so normally, how many chromosomes would you see in a karyotype of Downs? And you should be thinking 47 because Downs is usually, most of the time, a trisomy 21, meaning you got 3 copies of 21. So that's an interesting tidbit. Back to the text. We are at the top of page 6 here. Good sentence to start things off. The T1118 translocation is not present in Helicobacter-associated gastritis, but is frequently found in gastric malt lymphoma. And what's interesting about this one clinically is that this is the one that really does not respond whatsoever to eliminating the underlying Helicobacter infection. Now, the 114, from what I understand, does respond a lot better. You get rid of the Helicobacter, and then the lymphoma does tend to shrink. Hate to use that word again. I wish my vocabulary was a little bit more on point right now. I don't know how I feel about vocabulary, you know, because it's like sometimes just using these magnanimous words is like, oh, it's cathartic, you know. It's like it really feels like a weight off of your shoulders. But then on the other hand, you know, it's like if someone doesn't know what you're talking about, is it worth it? And the answer to that, I think, is no. It's like, why in the world would I walk around using 6 syllables when 1 or 2 would do, you know? So it's like, So you got an 1118 and then you got a 114 translocation. And they both involve nuclear factor kappa beta signaling. And NFKB is a transcriptional factor that's going to allow for transcription of a specific set of genes involved in the immunologic response to stress. So anytime there's oxidative stress in the cell or the detection of a pathogen from outside the cell, or even things like reactive oxygen species, yeah, that can trigger nuclear factor kappa beta. And so it will directly cause the expression of genes that will upregulate different cytokines associated with the inflammatory response. That's nuclear factor kappa beta in a nutshell. Diagnosis, usually endoscopic. So that's our gastric MALToma. Again, we really didn't say anything about the diffuse large B-cell lymphoma, and I think that's because that'll be in a later SDL. Now we have a brief paragraph on lymphoma of the small intestine. What you ought to take away from this is that there are 3 subtypes of small intestinal lymphomas. You've got your IPSID, which is your immunoproliferative small intestinal disease, which is characterized by secretion of alpha heavy chains by tumor cells. So remember we said light chain restriction. This is kind of like heavy chain restriction in this setting. It's like they're only making alpha heavy chains. And if you were to look at the heavy chains, well, you would expect to see different heavy chain populations expressed or shot out by these B cells. But you only see alphas. Oh, that's got to be a tumor, you know. And remember that Campylobacter jejuni infection is associated with that small intestinal lymphoma that secretes alpha heavy chains. It's also known as alpha chain disease. And remember that Campylobacter jejuni is associated with Guillain-Barré syndrome, which is going to be a ascending paralysis. And remember too that it's kind of here and then gone, I believe. I think you can get over that Guillain-Barré in like 6 to 8 weeks or so. But if you see any paralysis, that's what you should be thinking on this particular exam. Remember also Campylobacter is a gram-negative comma-shaped bacteria, just like Helicobacter is. And so what's going to set Helicobacter apart from Campylobacter is that Helicobacter, one of them is oxidase positive. I can't remember which one right now, but you're definitely going to do the urease breath test for Helicobacter, and then hopefully, you know, if it's a good question, like it might tell you, hey, like here's your immunoglobulin from the blood against Campylobacter. That would be real nice, right? What else? You can get reactive arthritis from Campylobacter. That's all I got off the top. Then we've got this enteropathy-associated T-cell lymphoma. So if it's a T-cell lymphoma, you're just like, bingo, that's my guy. And it's associated with celiac disease, which might get called celiac sprue, which might get called gluten-sensitive enteropathy. A lot of synonyms for these different medical terms. And then, love this, category C, other lymphomas. Thanks. So how do these lymphomas of the small intestine present? Abdominal pain, palpable mass, ding, 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 ding. That's what you're going to get most of the time because question stems tend to go with how the disease should theoretically present. You know, it's like they're not trying to, they are not throwing you curveballs. They throw you fastballs on pathology questions. Anorexia, loss of appetite, don't want to eat. GI bleeding, obstruction, perforation. So it's handy to be familiar with what all those different symptoms mean and what they present as, because how many different pathologies have we seen that have caused obstruction, right? And so that can be a source of abdominal pain, and so that can lead into the, and then there are different types of abdominal pain, which we haven't really covered yet. But not a lot of GI stuff is diagnosed based on symptoms alone. Colorectal lymphoma. If you see it, it will be a diffuse large B-cell lymphoma most commonly. And there's absolutely nothing here in this SDL about it, so I don't think you'll get asked about it. Malt lymphoma does respond favorably to therapy. Really good survival for it. So that's our Malt lymphomas. Remember the trisomy 3. Remember your translocations, 11, 18, 114. And then remember the genes involved for the translocations too, I'd probably say. Just, you never know. Gastrointestinal stromal tumors are c-KIT positive. So if you see that in a question stem, c-KIT positive tumor, it's a stromal tumor. Your parenchyma is the part of an organ or a tissue that does the work. So if we're talking about the brain, then the parenchyma is the neuron. And if we're talking about the heart, the parenchyma of the heart would consist of cardiomyocytes. But stroma, that's your supportive scaffolding. That's the architecture of a tissue that gives it its shape and allows it to sit in a particular place constantly and not get pushed around. And the cells that compose the stroma are fibroblasts and myoepithelial type cells, those that derive from the mesenchyme, which is kind of a germinal matrix of glue that all of your connective tissues do arise from at some point. So the SDL does go out of its way to mention that you might see a leiomyoma, leiomyosarcoma, schwannoma, or even a glomus tumor in the stomach. But what a gastrointestinal stromal tumor, or a GIST, refers to is a tumor originating, we think, from interstitial cells of Cajal, which are the pacemaker cells of the enteric nervous system and regulate bowel contractions. Now, they express this KIT receptor, so we can immunostain for KIT, and that's where our c-KIT staining comes from. The cells of Cajal themselves are something that will get hit on in one of the very first physiology lectures, I'm sure. What you need to know right now, if you haven't studied them already, is that they're not neurons, but they do propagate action potentials. So they can take action potential and pass it on to smooth muscle later down the line through basically gap junctions. And they're interconnected and they're woven together in grassroots type of envelopment. And they do go around the bowel, and they are not found in one particular layer. They're as deep as the muscularis mucosa of the mucosal layer, and they go as far out as both of the longitudinal layers of smooth muscle. So these stromal tumors will look spindle celly on histology because they're connective cells. Peak onset 60 years old. They're clinically silent usually until they grow larger than 2 centimeters, and that 2 centimeters rule applies to most cancers from what I gather. That's kind of like a size threshold at which you'll really start seeing some different symptoms, and especially an increased metastatic risk. Symptoms of stromal tumors include GI bleeds, obstructive symptoms, and these tumors are commonly fast growing, so bleeding is very common as a symptom. And obstructive symptoms are usually site specific. I'll remark on that periampullary lesion. Periampullary, around the ampulla. Well, what ampulla? Well, the ampulla of Vater, which is the major papilla of the pancreas protruding into the GI tract. Although I guess the gallbladder has an ampulla too. I haven't got there yet. I want to look that up. Oh yeah, that's what I thought. That's what I thought. So the gallbladder connects to the ampulla of Vater, if you could look right here. Yeah. So the gallbladder and the pancreas drain into the duodenum from the same site. So when you see periampular pain or lesions, that's the ampulla in question. Metastatic disease present in 15 to 50% of patients. It's wide. Know that metastasis may occur with this particular type of tumor. It tends to go to the liver, which should make sense because that would be the easiest and the very first route of circulatory spread, hematogenous spread of this tumor would be through the hepatic portal vein and into the functional parenchyma of the liver. Although you may also see seeding, cavity seeding into the peritoneum, because this is a tumor that does start off submucosally. It's a pretty deep tumor to start with, so it doesn't have to grow far to be able to chew through the outside of the GI tract. You know, a lot of tumors, that Malt lymphoma we just saw, for example, like it's going to be popping inside the lumen of the GI tube. But then this tumor might grow outside, and so you do have a big risk of perforation, body cavity seeding there. You might see ascites in the setting of peritoneal metastasis, and that's going to be fluid edema of the abdominal cavity. And the reason you might see ascites in a metastasis is because that metastatic mass, as it keeps growing, there's a larger and larger and larger progressive risk that it's just going to clamp down on a vein and obstruct its flow. And so, you know, backwards, upstream from the obstruction, there's going to be a high, very, very high buildup of hydrostatic pressure there. And then that's going to just naturally diffuse out of the blood vessel. So is that going to be an exudate or a transidate? Oh, that's going to be a transidate. Yep. And then also, I mean, if you get a metastasis right next to the portal vein and you get portal vein compression, well, goodbye. Yeah, there's ascites in like 2 days, 1 day for you. So these tumors do start off in the submucosa or the muscularis propria, but they may develop in any portion of the gut wall. And if you look at them, what do you see? You see spindle cells here in A, or you see epithelioid cells, meaning they look like epithelial cells, but they're not epithelial cells. And then here's a C-kit immunostain, and I mean, this just looks like hair. Like, that doesn't even look like a tissue, so you should be looking at that, and it's just like, do you think that that is a lymphoma? Do you think that is an adenocarcinoma? You know, so that's easy. And there it is with words: cytologically bland spindle cell or epithelioid tumor set in a richly vascularized stroma. C-kit positive. Might be, you might be able to stain it for platelet-derived growth factor receptor alpha. All the possible mimics of stromal tumors are C-kit negative. There we go, love it. And one more time, said it at the beginning, saying it again at the end, you might see leiomyoma. Hey, you might, there's a lot of smooth muscle in the GI tract. It's for sure not going to be in the mucosal layer if you get a leiomyoma or leiomyosarcoma. And so remember, I think that, what do we got for leiomyoma and sarcoma? Is that Vimentin or Desmond? I can't remember. Let's look that up. Oh, great Googling, Wade. Yeah, killed it. Well, I'm not finding anything, so I'll just post a comment for what leiomyoma is staying for. So let's talk about carcinoid tumors. These dudes are cool. They're neuroendocrine tumors growing from enterochromaffin cells distributed throughout the GI and bronchopulmonary systems. So these cells stain with chromium, reflecting how they contain serotonin. We have already talked about carcinoid tumors, actually, and we talked about it back when we talked about valvular lesions of the heart. Remember, carcinoid syndrome involves two heart valves. Which valves? Tricuspid and pulmonic. And what are the specific lesions? You usually see a tricuspid regurgitation. That's the most common, followed by pulmonic valve stenosis. So it's a right-sided heart problem. Why is it only the right side of the heart that gets hurt? Well, because the damage is mediated by serotonin, and serotonin gets metabolized by the lungs and inactivated, and so it doesn't reach the left side of the heart. So what does the damage look like? Plaques, raised bumpy lesions, maybe a little off-colored on gross anatomy, and the lesions consist of smooth muscle proliferation and fibroblasts too, and a lot of elastin in that tissue as well. So how did serotonin get into the heart to cause this reactive lesion? Because that's what it was the heart reacting to high blood serotonin. Well, you had a carcinoid tumor in the liver. But we learned that that wasn't the primary tumor. That was a metastatic carcinoid tumor. Now, the primary carcinoid tumor is what this STL is talking about. And you find the primary carcinoid tumor in the GI tract, usually the small intestine. You can also find it in the bronchus too. But if you did see a primary carcinoid tumor in the bronchus, do you think that you would get carcinoid syndrome from it? And I'm thinking, no, probably not, because serotonin's deactivated by the lungs, and most of the blood that's draining out of that bronchial carcinoid tumor is going to go through the lungs. I'm dead wrong about that, actually, because the bronchus is going to be like, well, the venous circulation of the lungs goes from small to large, so the bronchus is like last stop before the big veins, before the heart. So I don't know what would happen in that situation. We're just focusing on GI carcinoid tumors now. I know that much. So these tumors start off in the small bowel usually, and then they get to the liver through the portal vein, and they jump in the bloodstream and take a ride up to the liver. And so then they'll seed the liver, and they'll grow big, and they'll secrete serotonin, and it'll get into the heart. So carcinoids are the most common neuroendocrine tumor, period. But very few of them actually cause carcinoid syndrome. The small intestine, as we've said, is the most common site, followed by the rectum and appendix. They've got a yellow appearance, and they're yellow due to cholesterol and lipid accumulation within the tumors. So if something looks yellow, grossly carcinoid tumor, check. And if you see these really speckled stains, like we're seeing in the rightmost picture here, or anything that looks like it's going to be a neuroendocrine stain, anything like chromogranin or neuroenolase, something like that, then easy diagnosis, carcinoid tumor. So that's not where the question will come from. The question's not going to be what is the diagnosis, because it's like, duh. Although I could see a differential being made on an ovarian metastasis, because we did get given the example of a Krukenberg tumor in the diseases of the stomach lecture. Remember that the adenocarcinoma of the stomach might metastasize down to the ovaries and cause it to just blow up in size. And so then you biopsy the ovary in a question stem, and they'd say, oh, you see signet ring cells, and you'd be like, adenocarcinoma. Or they might say, oh, you're seeing uniform cells with scant pink granular cytoplasm and a round oval nucleus, and you'd say, oh, that's probably a metastatic carcinoid tumor. So there's your stains. It'll cause carcinoid syndrome mediated by serotonin. Number 1 syndrome is flushing. Number 2 is diarrhea. And you're going to get flushing because serotonin while it vasoconstricts some tissues, like in the brain, it vasodilates others, and it vasodilates the skin. And so that's where you get the redness of the skin from. And serotonin syndrome and diarrhea, too, is a particularly common symptom that leads you to think GI involvement. So carcinoid syndrome occurs after the tumor metastasizes, and that's because, well, where's the primary cancer? Small bowel, appendix, rectum. So if those tumors spit serotonin into the venous circulation, where is it going? It's going into the liver. And so serotonin is metabolized by the liver, just like it's metabolized by the lungs. Why? Because the liver, I mean, this thing has like cytochrome P, like Bill Gates has dollar bills, you know? So serotonin gets to the liver, and there's no more serotonin on the other side of the liver, no. And so you've got to have a metastasis to like zone 2 of the liver, you know, on the other side of the portal vein. It's got to get out of the portal circulation, and it's got to get into the liver. And then it'll be spitting serotonin. Where is it going to be putting serotonin? Well, into the hepatic vein, which goes into the inferior vena cava, which goes into the right side of the heart. So that's why you get carcinoid syndrome only from the metastasis, not from the primary cancer. How do we diagnose this? Plasma CGA concentration is a good sensitive marker of neuroendocrine tumors. To diagnose carcinoid syndrome, we'll take urinary 5-HIAA, hydroxyindole 3-acetic acid. And you're not going to see that, again, you're not going to see urinary 5-HIAA, which is a serotonin breakdown product, if the thing hasn't metastasized, because there's going to be no serotonin to break down into 5-HIAA. It'll only be if the thing's already metastasized elsewhere than the gut that you're going to see that level elevated, and the patient will have the carcinoid syndrome too, most likely. So the prognosis for this, what this paragraph is telling you is that they're going to metastasize these carcinoid tumors if they arise primarily from the jejunum and the ileum. Otherwise, they're more than likely going to stay where they are. So like foregut carcinoid tumors, rarely metastasized, generally cured. So you're not going to see a carcinoid syndrome question from a foregut carcinoid tumor. Likewise, it's not going to be a carcinoid syndrome question like what's the most likely complication of a carcinoid tumor in the appendix. It's not going to be carcinoid syndrome. It's going to be something like diverticulitis, you know, or like obstruction. So that's it. And I want to talk briefly now about the differential of these cancers plus adenocarcinoma of the stomach, because those are the 4 cancers that we've got on this upcoming exam. And so those are answer choices A, B, C, and D to me. So know these well and make the diagnosis like that. And then these questions really should be gimmies. They should be layups on this exam. So histologically, if you get a picture of a cancer, then just say thank you, because that's going to give it away. If you see a lot of lymphocytes, obviously, you know it's going to be a MALToma, and so then you might have to make a farther diagnosis into a subcategory of MALToma. But then that should be given away based on where it is, and then there should be something about T cells in there if it's that T cell type in the large intestine. Remember, MALTomas are usually in the stomach too. If you see a lot of neuroendocrine cells, which have that speckled chromatin, and they have pretty regular looking appearance, you know, they're not messed up and they're not spindle cells, that's your carcinoid tumor. And remember, the carcinoid tumor likes to grow in the small bowel, the appendix, and the rectum. If you see signet ring cells, remember those are the bloated ones with lots of mucus in the cytoplasm, and they've got this nucleus that's been pushed to the periphery of the cell by the mucus accumulation within the cell. And that's your gastric adenocarcinoma. Remember that has a progression that can be well differentiated or poorly differentiated. And as it de-differentiates, it tends to get serous, which means fibrotic or dense or leathery in nature. And so if you have those all over your stomach, then there's a name for that, and that's called linitis plastica. And what that might get shown to you as or told to you as is like water bottle stomach, which is like, I mean, I ain't seen a water bottle like that, you know, like I'm not from Skyrim, but like That's how they'll tell it. And then anatomically, if they tell you this tumor grew out of the submucosal layer, you know, or this tumor grew out of the muscularis layer, you're just like, oh, stromal tumor or like leiomyoma. Now, if it metastasizes, a couple of these tumors are really prone to metastasize, and especially if it's that left supraclavicular node, you're thinking carcinoid tumor. Actually, no, you're thinking adenocarcinoma all the way for that, and you're probably also thinking the MALToma from the stomach. Now, if you find a metastasis in the liver, that's the one that's most likely to be a carcinoid tumor. And in conclusion, quick reminder about our stomach cancers, our gastric adenocarcinomas. Those do tend to have Wnt pathway mutations, especially in that E-cadherin gene. Anything creating a gain of function for beta-catenin, because then beta-catenin is going to be what upregulates transcription of pro-survival genes and leads to a cancerous mutation. And remember that adenomatous polyps are precursor lesions for cancer in the stomach, and that those are also associated with APC knockouts, loss of functions, as well as loss of functions in the tumor suppressor genes MLH1 and MSH2. So 3 suppressor genes right there for that polyp, which is typically the precursor lesion for the adenocarcinoma. So don't forget about those genes, and understand that the number 1 risk factor for a gastric cancer is Helicobacter pylori infection. That's it. Thanks for listening.